Welcome back, everybody, for another deep dive.
Yeah.
Today, we are going to be looking at something that's very, very important for nurses at every level, and that is abdominal assessment.
Absolutely.
And we're going to be basing this deep dive on a really, really excellent textbook all about physical examination.
Yeah.
And I think you're going to be surprised by how much depth there is to this topic.
Oh, yeah, for sure.
So get ready for some anatomical aha moments.
Absolutely.
And some really practical tips that I think will help make you a better clinician.
For sure.
Okay. So let's get into it. When we think about abdominal assessment, it's tempting to just picture this flat surface, right?
Yeah.
But it's not like that at all.
No, not at all. It's very dynamic. You've got so much movement going on in there.
So let's just start with a really basic anatomy overview.
Okay.
What are the things that make the abdomen so unique?
Well, you can think about it as a container, right?
Okay.
But it's a flexible container, so you have the diaphragm at the top of that container. You've got your pelvic bones at the bottom, and then you've got layers and layers of muscle all around. And so what this does is it gives the abdomen a lot of flexibility and movement.
Right.
And then inside you've got your organs, but it's not just organs all crammed in there together.
Right.
You've got this amazing lining called the peritoneum.
Okay.
Which is this really smooth, glistening lining. And it's so important because it helps reduce all the friction between the organs as they're moving around with every breath, with changes in posture, all of that.
Yeah, that's a really good way to picture it. Not just a flat, static space, but something that's constantly adapting and changing and moving.
Absolutely.
So, I think that's a really important takeaway for anybody doing palpation. Right?
Yeah.
It's not just you're feeling the organs.
Exactly.
You're feeling all these layers of muscle and peritoneum.
Layers of muscle and peritoneum, that's a really important thing to remember.
Exactly.
And to help us kind of navigate this really complex landscape, we have this thing called the quadrant system.
Yeah, I love the quadrant system.
Yeah.
It's like our treasure map of the abdomen.
It is.
So can you just remind us quickly how that works?
Okay, so we divide the abdomen into 4 quadrants.
Okay.
You have the right upper quadrant, or the RUQ, the left upper quadrant, or LUQ, the right lower quadrant, RLQ, and the left lower quadrant, LOQ.
Got it.
And if you just picture a plus sign over the belly button, that kind of gives you the visual of those 4 quadrants.
Okay, yeah.
And that system is so useful because it just helps us when we're communicating about the location of organs, or when a patient comes in with pain, we can start to kind of narrow down the possibilities based on which quadrant that pain is in.
Exactly.
Yeah.
So if somebody says I have lower quadrant pain, you start thinking, okay, appendix maybe?
Right. That's a good first thought.
Well,
but remember, it's not a completely rigid system.
Right.
We're talking about a 3-dimensional space here.
Yeah.
Organs overlap.
For sure.
Pain can refer. So, just because something seems like it's an RLQ problem,
right,
it might actually be something stemming from the pelvis, like an ovary, for example.
Totally. Yeah, it's a good mental shortcut, but it's not like a rigid boundary.
Exactly.
Now, I've always wondered this. Can you actually feel all of the organs in the abdomen?
You can't feel all of them.
Okay.
No, some of them are either tucked away in a place that you can't really get to them.
Okay.
Or they have a texture that just makes them not palpable.
Okay.
So the liver, for instance, is usually tucked up under the rib cage, so you might be able to feel the edge of it.
Okay.
But for the most part, you're not going to palpate the liver unless it's enlarged.
Okay. So if you feel liver, that's a bad sign.
Exactly. That's a good sign that something's going on.
That makes sense.
The spleen is another good example.
Okay.
It's on the left side, tucked partly under the ribs. And if you can feel the spleen, that's a red flag.
What would that mean?
That could mean infection. It could mean inflammation or some kind of blood disorder.
Wow.
So if you palpate an enlarged spleen, that's a big deal.
So I guess knowing what's normally palpable really helps you figure out when something's not right.
Absolutely.
What about the kidneys? Now, those are pretty well hidden, aren't they?
The kidneys are a great example. They're actually located behind the peritoneum.
Wow.
Against the back wall of the abdomen.
So they're really protected.
They're very protected, and they've got that rib cage
partially
shielding them as well.
Okay, so how do we even assess those if we can't really feel them?
Well, we use landmarks.
Okay.
And we use specific techniques.
Yeah.
So there's this area called the costovertebral angle, or the CVA for short.
Okay.
And that's the area where the 12th rib
Okay.
meets the spine.
Okay.
And if we tap gently on that area, so we call that fist percussion,
Okay.
and the patient reports pain,
Yeah.
that can be a sign that there's something going on with the kidneys, like a kidney infection.
So that one little area, the CVA can tell you a lot.
It can tell you a lot.
That's fascinating. And you mentioned earlier the pelvis.
Yeah.
So how does the pelvis play into all of this when we're doing an abdominal assessment?
Well, the pelvic cavity, it's continuous with the abdomen.
Oh.
And it contains really important structures like the bladder, the reproductive organs, and parts of the intestines.
So are you saying that abdominal pain could actually be coming from a pelvic issue?
Exactly.
And vice versa?
And vice versa. You got it.
Okay, so pain can be a little misleading.
It can be very misleading.
So we always have to think about both abdominal and pelvic causes.
Right.
When somebody's having symptoms in that region.
Exactly.
Okay, good reminder to think broadly. I love it now. Abdominal pain is like the #1 reason people come into the hospital or the clinic or whatever.
One of the most common complaints, for sure.
So how do we even begin to decode that and like differentiate between all the different causes of abdominal pain?
Well, that's where understanding the different types of abdominal pain comes in.
Okay.
There are 3 main categories of abdominal pain.
Okay.
We have visceral pain, somatic pain, and referred pain.
All right. I'm intrigued. Tell me more about those.
Okay. So imagine you're stretching a balloon.
Okay.
That's kind of what visceral pain is like.
Right.
It happens when hollow organs like the intestines
Okay.
are stretched or they're contracting really forcefully.
Got it.
And it's usually a vague kind of pain. It's hard to pinpoint, and it's felt somewhere near the midline of the abdomen.
Okay. So it's like kind of a general alarm bell.
Exactly. It's
Yeah.
telling you, hey, something's wrong.
Yeah.
But it doesn't tell you exactly where.
Okay.
Now think about pressing on a bruise.
Oh.
Yeah. That's what somatic pain is like.
Okay.
Also called parietal pain.
Mm-hmm.
And that comes from inflammation of the peritoneum.
Oh, that lining we talked about.
That lining we talked about. Exactly.
Interesting.
And that kind of pain is usually sharper, it's more intense, and it's easier to localize.
So it's like a spotlight.
Exactly. It's like shining a spotlight on the problem area.
Very cool. Okay. And then you said referred pain.
Right. Referred pain is when the pain is felt in a completely different spot than where the problem actually is.
Oh, wow.
So it's kind of like a prank call. You know, the pain is coming from one place,
Yeah.
but it's showing up somewhere else entirely.
Wow. That's so weird.
The classic example is pain in the shoulder from a heart attack.
Oh, wow. The body's so crazy.
It is.
So it sounds like the location and the quality of the pain both tell us different things.
Absolutely. They work together to give us those clues.
Okay. Can you give me an example of that?
Sure. So early appendicitis, for example.
Okay.
It often starts as this vague visceral pain,
Okay.
kind of around the belly button.
Mm-hmm.
But as the appendix gets more and more inflamed, it starts to irritate that peritoneum,
Well,
the lining that we talked about.
right.
And then the pain shifts and it becomes a sharp somatic pain
Interesting.
that's more localized in the right lower quadrant.
So the pain actually moves as the problem progresses.
Exactly. It can migrate.
It's fascinating.
So asking the patient to point to their pain,
Yeah.
that's really crucial for diagnosis.
It's like putting together all the pieces of the puzzle.
It is. It is.
Okay, so we've talked about pain.
Right.
Let's move on to some of the other symptoms that we might see with abdominal issues. And let's start with like those classic GI symptoms.
Okay, sounds good.
What are some of the key ones that we really want to pay attention to?
Well, nausea and vomiting are always important to assess.
Yeah.
And, you know, it's not just about asking, are you nauseous? Are you vomiting?
Right.
We need to dig deeper and figure out, you know, what exactly is going on.
Like
Is it
legit.
vomiting? Is it regurgitation?
Hmm.
Is it hematemesis?
Yeah.
So vomiting blood.
Yeah.
Each of those tells a different story.
So we're getting specific with our questions.
Exactly.
And then what about diarrhea and constipation? Those are other
Yeah.
ones.
Those are the other common culprits. And again, we want the details.
Okay.
How often are you going?
Mhm.
What's the consistency? Like, are there any other associated symptoms? Blood in the stool mucus.
Right.
These are all important clues.
We're like little detectives
We are. We are.
looking for clues.
That's a great way to put it.
And then, of course, there's jaundice, that yellowing of the skin and eyes.
Right. Jaundice is a sign that there's too much bilirubin in the blood.
Okay.
And that often points to a problem with the liver or the gallbladder.
So it's another one of those things that, you know, if you see it in your patient, that's a sign that you need to investigate further.
Absolutely a visual cue that you shouldn't ignore.
Now that we've sort of explored the digestive system,
Yeah.
let's shift our attention to another really important part of the abdomen, and that's the urinary tract.
Okay.
What are some of the common urinary symptoms
Okay.
that can give us some insights into what's going on?
Well, dysuria, urgency, and frequency are a classic trio. So dysuria is that painful burning sensation when you urinate,
Mm-hmm.
often a sign of a urinary tract infection.
Right.
Urgency is that sudden, overwhelming need to go.
Yeah.
And frequency is just going more often than usual.
So if you see all three of those together, you're thinking UTI.
Exactly. That's a good bet.
And then we have polyuria
Right.
and nocturia.
So polyuria is excessive urination.
Okay.
And nocturia is waking up at night to pee.
Okay, so peeing too much or waking up at night, it seems like a simple thing.
Right.
But it can actually have some pretty complex underlying causes.
Absolutely. It could be diabetes. It could be certain medications, all sorts of things.
And then what about urinary incontinence?
Urinary incontinence, that involuntary loss of urine,
Yeah.
that can be really distressing for patients and really impact their quality of life.
Absolutely.
And there are different types. You have stress incontinence, urge incontinence,
Right.
overflow incontinence, functional incontinence, mixed incontinence.
Right.
So it's a sensitive topic,
Yeah,
but it's an important one to address.
totally. We need to be really mindful and compassionate about how we approach those conversations.
Absolutely.
And then what about hematuria?
So hematuria, that's blood in the urine.
Okay.
That's always a cause for concern and needs further investigation. And we need to distinguish between gross hematuria, which is visible blood that you can see,
Okay.
and microscopic hematuria,
Okay.
which is only detected through lab tests.
Okay.
And, of course, with female patients, we always want to rule out menstrual blood, of course,
Right.
as the cause.
Okay, so we've talked about symptoms.
Yes.
Let's actually get hands-on
Okay.
and talk about the physical exam itself.
All right.
What are those essential techniques?
For a thorough abdominal assessment, so the physical exam involves 4 steps: inspection, auscultation, percussion, and palpation.
All right, you want to do me in that order?
You want to do them in that order every time.
Okay. So let's walk through each of those steps. What are we looking for? What are we listening for?
So we start with inspection,
Okay.
just looking at the patient, taking in their overall appearance.
Mm-hmm.
What's the shape and contour of the abdomen?
Okay.
How does the skin look?
Yeah.
The umbilicus? Are there any scars, rashes, distended veins?
Yeah.
Is the abdomen symmetrical? All of these observations can give us valuable clues.
It's amazing how much you can tell just by looking.
It really is.
All right, what about auscultation?
So with our stethoscope, we're going to listen for bowel sounds.
Okay.
And the character and frequency of those sounds can tell us a lot about intestinal activity.
Right.
We're also listening for any brutes.
What's a brute?
A brute is a sound that might indicate that there's a blockage in an artery.
Oh, wow. Okay, so we're listening for all sorts of sounds in there.
We are. It's like listening to the internal symphony of the abdomen.
I love it.
All right. Then we move on to percussion.
Okay.
So percussion is tapping on the abdomen with our fingers
Mm-hmm.
to assess the density of the underlying structures.
Oh, okay.
So we're listening for changes in sound.
Okay.
We might hear tympany, which indicates air, or
Mhm.
dullness, which suggests fluid, or a solid mass.
Okay.
Percussion can help us determine the size of the liver and spleen.
Right.
And it can also help us detect things like ascites, which is an accumulation of fluid in the abdominal cavity.
Okay, so it's like we're using sound to create a map of what's underneath.
Exactly.
And then finally we have palpation.
Yeah, palpation. That's when we actually use our hands to feel for organs, masses, or areas of tenderness.
Okay.
And we start with light palpation, just to get a general sense of the abdomen, and then we move to deeper palpation
Okay.
to assess specific organs.
Right.
And throughout palpation, we're looking for anything out of the ordinary,
Mhm.
while also being gentle and watching the patient's face for any signs of discomfort.
Right. So it's a balance
It's a balance.
of firmness, but also sensitivity.
Absolutely.
Okay. So that's sort of like the overview of the techniques.
Right.
Now, are there any special techniques or pro tips that you use for specific conditions?
Oh, yeah, for sure.
Okay.
So let's say we suspect ascites.
Okay.
We might use techniques like shifting dullness or ballottement.
Okay. I've heard of those. Tell me more.
Okay, so shifting dullness involves percussing the abdomen in different positions.
Okay.
And we're looking to see if the areas of dullness move.
Oh, wow.
And if they do that, suggests that there's free fluid in there.
So it's like you're using gravity to help you map out where the fluid is.
You got it.
That's so cool. What about ballottement?
Okay, so ballottement, you can think of it kind of like bouncing a basketball.
Okay.
So we're using this quick tapping motion
Okay.
to see if we can displace the fluid
Okay.
and feel the underlying organ.
Wow.
And if you feel a solid structure rebound against your fingers,
Yeah.
that suggests ascites.
Okay. That's amazing.
So it's all about using those special techniques to confirm our suspicions.
It's like having extra tools in your diagnostic toolkit.
Exactly.
Now, what about a condition like appendicitis?
Oh, yeah. So for appendicitis, we might check for McBurney point tenderness.
Okay. And where's that?
So McBurney point, it's located about 2 inches from the superior iliac spine
Okay.
on a line drawn to the umbilicus.
Got it. So McBurney point is like the X marks the spot for appendicitis.
You got it.
And if they have pain there,
That could be a sign.
that could be a sign of appendicitis.
It could be.
Now, are there any other signs that we should be aware of when we're thinking about appendicitis?
Oh, yeah, for sure. So McBurney point tenderness is a classic sign.
Yeah.
But not all cases present in the textbook way.
Right.
So we also have things like Rovsing's sign,
Okay.
the psoas sign, the obturator sign,
So these are all basically maneuvers to assess for,
peritoneal irritation.
right, which is a hallmark of appendicitis.
Exactly.
So just because they don't have pain at McBurney point doesn't mean
Doesn't mean you can rule it out.
we got to keep thinking.
Keep thinking.
What about acute cholecystitis?
Oh, so for acute cholecystitis, that's inflammation of the gallbladder, we check for Murphy's sign.
Okay, tell me about Murphy's sign.
So for Murphy's sign, you're palpating in the right upper quadrant
Okay.
while the patient takes a deep breath. And if the patient suddenly stops inhaling
Yeah.
because of pain,
Yeah.
that's a positive Murphy's sign.
Okay.
And it suggests gallbladder inflammation.
Wow. It's amazing how these little techniques can be so specific.
It's amazing what you can find when you know what to look for.
Are there any other pearls of wisdom that you want to share about abdominal assessment?
You know, one of the most important things I've learned over the years
Yeah.
is to really pay attention to the patient's story.
Yeah.
Sometimes the key to cracking the case isn't in the physical exam.
Right.
It's in the details that they share about their symptoms. It's about connecting the dots between their subjective experience
Absolutely.
and our objective findings.
I love that. And it's a good reminder that abdominal assessment is not just about the physical exam. It's about listening to the patient,
Absolutely.
putting all the pieces together.
It's a holistic approach.
Exactly. And I think it's also important to remember that, all these techniques that we've talked about, they're really important. But the real art of abdominal assessment comes with experience.
Absolutely. The more you practice, the more confident and skilled you'll become
Right.
at recognizing patterns and those subtle cues.
Totally. So this has been a great overview of the basics.
Yeah.
But now let's get into some more specifics
Sounds good.
and talk about how to apply all this knowledge in real-life clinical situations.
All right. Let's do it.
So stay tuned, everybody. We'll be right back.
One thing that often gets overlooked is how age and body habitus can really influence our assessment.
Yeah? Tell me more about that.
So in infants, for instance, the abdominal wall is much thinner.
Okay.
So it's actually easier to palpate organs.
Makes sense.
But as we age, we lose muscle tone, fat distribution changes.
Right.
And all that can make palpation more challenging.
So it's almost like the opposite.
It is, yeah.
And as you get older, it gets harder.
It can definitely get harder.
And I imagine it's probably harder to assess someone with like a larger abdomen as well.
Yeah, obesity can definitely make it difficult to feel organs and masses.
Okay.
We might need to adjust our palpation depth
Right.
or use different techniques.
Yeah. You really got to work for it.
You do.
It's like finding a needle in a haystack.
Exactly.
So, we've talked about a lot of these like textbook findings.
Right.
But in real life, things aren't always so clear cut.
Oh, absolutely.
What do you do when you've got a case that's not so straightforward?
Well, that's where experience and critical thinking really come into play.
Right.
Not every patient is going to present in that textbook way.
For sure.
So it's about being observant,
Yeah.
picking up on those subtle cues, and being willing to consider different possibilities.
And not being afraid to ask for help
Absolutely.
if you need it.
Never be afraid to consult with your colleagues,
Right.
review the literature, or even seek guidance from more experienced clinicians that can really help us refine our skills and make sure we're providing the best possible care.
Well, this deep dive has been so insightful. I feel like we've covered so much,
We have.
from the basic anatomy all the way to these like advanced assessment techniques.
Yeah, it's been a great overview.
So as we wrap up, is there like one key takeaway that you would want to leave our listeners with?
I think the most important thing to remember is that abdominal assessment, it's a journey, not a destination.
I love that.
It's a skill that we continue to develop throughout our entire careers.
Yeah.
So be curious, ask questions, and never stop learning.
Yeah.
The abdomen, with all its complexity,
Right.
will always have something new to teach us.
That's a great note to end on. And, every patient encounter is an opportunity to learn something new.
It is.
So we want to hear from you, our listeners. What are your go-to techniques for abdominal assessment?
Yeah.
What are some challenges that you've encountered?
Absolutely.
Share your experiences and your questions in the comments below.
We love to hear from you.
Until next time, Happy assessing everybody.
Yeah.
Yeah.
It really is. And, I think it's easy to get caught up in all the techniques and the specific signs.
Right.
But we have to remember that abdominal assessment is really about,
Yeah.
integrating all of that information.
It is.
The anatomy, the symptoms, the exam findings, to create this coherent picture
Exactly.
of what's going on with the patient.
A holistic picture.
Exactly. And that takes practice.
Absolutely.
And experience and, ongoing learning.
Always learning.
So we've talked a lot about, what we're supposed to feel and hear and see.
Right. Those textbook findings.
Exactly. But in real life,
Yeah.
things can get messy.
Oh, for sure.
How might things like age,
Yeah.
body habitus,
Absolutely.
even cultural factors, how do those things influence your abdominal assessment?
That's a great question, and that's something that, you really learn with experience.
Yeah.
And there's no one right answer.
Right.
But it's about being aware of those individual differences
Yeah.
and how they might affect what you're seeing and feeling and hearing.
Exact. So much food for thought.
So much.
So we want to hear from you, our listeners.
Yes.
What are your go-to techniques for abdominal assessment?
Yeah. What are your tips and tricks?
What challenges have you encountered?
Absolutely.
Share your experiences, your questions in the comments below.
We'd love to hear from you.
Until next time, happy assessing, everybody.